Hello and welcome back. So today I'll be talking about significant but poorly localized abdominal pain. We'll start with a case vignette and we'll analyze the case, and then that'll lead us to the importance of imaging in such cases. So in the previous video in this series, I've talked about chronic pancreatitis, the pathophysiology and the clinical outcomes of that pathophysiology, and we've covered autoimmune pancreatitis theoretically from its mechanistic basis to the clinical features that develop. So we'll try to use symptom analysis to get to chronic pancreatitis first, and then we'll try to extend our pathophysiological understanding of the disease to radiology and try to then use radiology to diagnose these disorders. So we'll start with the case. The case is, as always, a patient of mine. So this is a 57-year-old gentleman who was detected to have diabetes mellitus 8 months back. Previously, he was started on SGLT2 inhibitors and he's presently poorly controlled, but he has no microvascular or macrovascular complications of diabetes, for which he has been screened elsewhere. Uh, there is no history of substance use or abuse, and now he is presented with abdominal pain for the last 1 to 2 years. So this was gradual onset of persistent, episodically worsening, deep-seated but poorly localized, dull aching, moderate to severe abdominal pain without any radiation, but prominently associated with loose stools. So he describes them as passage of 2 to 3 semi-solid stools per day. The volume per purge of stools is normal as per the patient. Subjectively, the patient describes it as having the stools as having oily consistency, and he says that they were difficult to flush. The episodes of loose stools resolve with prolonged fasting and worsen a few hours after ingestion of meals, and he's noticed that it is particularly prominent after ingestion of oily foods. There is, however, no passage of blood or mucus in stools, and there are no rectal symptoms. So we'll come to what rectal symptoms are in an approach to diarrhea. Essentially, this includes tenesmus, feeling of incomplete evacuation. Okay. Now, importantly, there is no history suggestive of nocturnal episodes of passage of loose stools, jaundice or generalized pruritus or vomiting, gastroesophageal reflux, or epigastric discomfort, unintentional weight loss, or features suggestive of fat soluble vitamin absorption, malabsorption rather, and no pedal edema. On examination, the general examination was within normal limits, and the abdomen, it was also soft without any hepatosplenomegaly. No palpable mass was present, um, and all baseline routine investigations are all within normal limits. So let's go ahead and review the causes of such a poorly localized but significant. So the patient is not able to say exactly where the pain is arising from in the abdomen, but it is still significant enough to cause problems to the patient. So again, as we've gone over the diagnostic framework in the previous video and the first video in this series, these are the possible causes. So of this, peptic ulcer disease seems unlikely because the patient does not have the abdominal pain that is suggestive of peptic ulcer disease, and outside of the remote possibility of gastrinoma causing the Zollinger-Ellison syndrome, there is no clear explanation for steatorrhea in a patient with peptic ulcer disease. It's not gastritis because that would not explain the symptoms. We'll get into this in the next sub series in this particular topic. There are no features of small intestinal bacterial overgrowth, as in there's no bloating, so that's a very unlikely. Um, Again, helminthic infections would not cause symptoms for 1 to 2 years. Propulsive gastroparesis and small intestinal pseudo obstruction or chronic intestinal obstruction are very unlikely because the patient is actually having increased stool frequency. Functional causes, very clearly, these are not the symptoms that are compatible with the functional abdominal pain. It could be vascular disorders, as it definitely could be a chronic mesenteric ischemia. However, the steatorrhea would be very difficult to explain unless the chronic mesenteric ischemia was affecting very specific parts of the GI tract, for example, the distal ileum. So that would be much lower down in the list. It could be chronic pancreatitis, the pain being explained by the chronic pancreatitis, and the steatorrhea being explained by the exocrine insufficiency that the patient has. Retroperitoneal fibrosis, endometriosis, aortic aneurysms, and primary sclerosing cholangitis are very unlikely. So as we've discussed with autoimmune pancreatitis, primary sclerosing cholangitis, or rather more aptly framed as IgG4 related sclerosing cholangitis, can coexist with chronic pancreatitis, and that could also be a cause of steatorrhea in this patient. So that obviously would require us imaging to further confirm. So before we go into the actual analysis of the case, the formal interpretation of the case, we also need to analyze the steatorrhea. This is again going to be discussed in much more detail in an approach to chronic diarrhea. However, basic understanding is required in order to analyze this case. How I like to follow, we'll try to derive a diagnostic framework for steatorrhea. So for that, we need to understand the normal physiology. Okay, so what happens is the fat digestion primarily happens within the duodenum. So you've got your duodenum, you've got your stomach, food enters into the duodenum from your stomach. Now this food has very low pH because of the acidity of gastric contents. So this pH must first be normalized. So the pH has to be increased. This is done by secretions that come from your pancreas. So this is the pancreas. Okay, so the pH is increased, and the pancreas secretes lipases, specifically pancreatic lipase, and that lipase requires normal pH to function. In addition to that, you've got bile acids coming into the duodenum from the common bile duct. Now, these bile acids are required because lipase can only digest fat once it has been emulsified. Whatever fat globules are there inside the food have to be first emulsified to produce small micelles, and that those micelles are then digested by the lipase into absorbable fat. Okay, so this is the normal physiology of what happens in the second part of the duodenum. Again, I'll talk about this in significantly more detail later. So the first thing that is needed is a normal concentration of duodenal bile acids. So if the duodenal bile acid concentration is too low, there will be decreased emulsification of fat, and non-emulsified fat cannot be effectively digested. So one prominent example of how this might happen is through obstructive jaundice. And obstructive jaundice naturally can be due to obstruction at an intrahepatic biliary site or to the extrahepatic biliary apparatus. So an example of intrahepatic biliary obstruction would be primary biliary cholangitis, but we'll see that it's a pretty extensive list. Similarly, for extrabiliary hepatic biliary obstruction, it could be a mass in the head of the pancreas obstructing the common bile duct and various other things. So, however, the important thing would be clinically there would be jaundice, because not only is bile acid removal being hampered, it is also bile pigment that is being hampered. Then, as the process progresses, bile acid accumulation and deposition within the skin would cause generalized pruritus, and eventually significant hepatic impairment would develop, but this would happen at very advanced stages. So hepatic function is usually preserved till very late in the disease course. The second problem that might arise is that duodenal fluid pH may be lower than the normal that is expected. So that means it is too acidic within the duodenum. This will result in ineffective activation of pancreatic enzymes. And the reason for this would be that there is too much H plus being entering into the duodenum from the stomach, because there's too much production of H plus. So this characteristically happens with gastrinomas, that is Ollinger-Elson syndrome, and that can cause steatorrhea. But obviously there is gastric hypersecretion that would also cause peptic ulcer disease like abdominal pain, which is not what this patient has. Okay, then you can have decreased pancreatic bicarbonate secretion, so production and secretion. So this will happen with chronic pancreatitis, and we've discussed the causes of chronic pancreatitis using a mnemonic, that is Tigaro. Now, as we've seen in all chronic pancreatitis, abdominal pain is a prominent complaint. This is the only exception to this rule is autoimmune pancreatitis, and endocrine insufficiency, that is diabetes mellitus, may also occur, especially in routine chronic pancreatitis. Now, the other thing that might happen is, even though the fat has been emulsified properly and the duodenal pH is normal, that is, it is adequately alkaline, you just may not have enough pancreatic lipase synthesis. So that can also happen if there is pancreatic exocrine insufficiency. So these are the two mechanisms by which steatorrhea happens in chronic pancreatitis. So that is that. Finally, all of this might happen, but the fat can just not be absorbed by the jejunum. So this would happen due to wall abnormalities or due to obstruction to the lymphatics that drain the jejunum predominantly. So we'll discuss this because there's a very extensive list of disorders, and we'll have to subclassify them as inflammatory cause and non-inflammatory. So we'll discuss this under approach to chronic diarrhea. Naturally, it will not just be fat malabsorption that will occur. Other macronutrient and micronutrient malabsorption would occur, and the clinical features of that would also develop. Now, as you can see, I've left something incomplete here. So if you have impaired enterohepatic recirculation of bile acid, so usually a single molecule or a mole of bile acid that is synthesized and secreted into the duodenum undergoes around 7 cycles of intrahepatic recirculation, as in it is absorbed at the ileum and then enters into the portal blood, reaches by the liver back, and then is taken and then put back into the bile, and that keeps happening again and again about 7 times before it goes in stool. So that is actually the main mechanism that maintains duodenal bile acid concentration. And if you have impaired ileal absorption of bile acids, the liver has to compensate for that by producing increased concentrations of bile acid. To an extent, the liver can compensate, but after a while it becomes very difficult. So particularly in advanced ileal absorptive defects, like in with ileal resection, especially longer than around 10 centimeters, Crohn's disease, ileal tuberculosis. Again, this is a long discussion in itself. You would end up getting malabsorption of fat because of decreased duodenal bile acid concentration. Now, obviously, the ileum also is involved in B12 malabsorption. So there would be B12 malabsorption resulting in anemia with macrovalocytosis. So that is what we would expect. Now, in our particular case vignette, we found that the patient did not have rather any jaundice or generalized pruritus. There was no evidence of hepatic functional loss. There was no anemia. The routine investigations were normal. The pain is not really that of peptic ulcer disease, and we'll talk about this in more detail as we come into peptic ulcer disease in this series itself. There is abdominal pain, which is poorly localized but significant. The patient has recently developed endocrine insufficiency of the pancreas, resulting in diabetes mellitus. There are no clinical features suggestive of autoimmune pancreatitis, but definitely, some cases of autoimmune pancreatitis do have abdominal pain as well. However, the pain is the prominent complaint. So autoimmune pancreatitis becomes very unlikely. Now, there is no evidence of any other macronutrient or micronutrient malabsorption. So you can see where I'm getting with this. that this patient likely has chronic pancreatitis with or without some kind of extrahepatic biliary obstruction. Mild hepatic extrahepatic biliary obstruction may also be there. We cannot really be sure. The possible etiologies therefore then become, as I just said, peptic ulcer disease gets ruled out. Ileal Crohn's with patchy GI disease also technically gets ruled out because there's no abdominal pain suggestive of ileal involvement, and there is too much abdominal pain that is not explained by that. And chronic mesenteric ischemia technically is again feasible. However, like I said, it would have to be very severe mesenteric ischemia, and it would have to affect the ileum, which is usually not the usual site for chronic mesenteric ischemia. So essentially, those three things get ruled out, and even clinically, I can tell you even on face value just through history that this patient has chronic pancreatitis. Okay, so that's fine. So this is a significant but poorly localized abdominal pain without vomiting, with features suggestive of steatorrhea and recently diagnosed diabetes mellitus without any complications of long-standing diabetes mellitus, making it likely attributable to this pathology. And the probable cause is chronic pancreatitis. Okay, so that's it. End of story. So why image? Why do anything else? So what I would do is confirm steatorrhea using a 48-hour stool fat estimation. Usual cutoffs use the 28 grams. If you do it for 24 hours, usual cutoffs use the 14 grams. If you do it for 24 hours, yeah, it would be 7 grams. Then PTINR maybe just to see if there is any hepatic functional dysfunction. But imaging, I don't know. Would I do imaging? So this is a patient again that was referred to me as a rheumatologist because there was a suspicion of autoimmune pancreatitis, or rather, actually, the abdominal pain was unexplained. Okay, that was the primary reason. So this patient had new onset of apparently unexplained pancreatic exocrine insufficiency. Now, on imaging, there were no features of obstructive jaundice. That is why the patient got referred to me. But we'll see what was there and how would be interpreted. And specifically, would this be based on imaging, would I change the diagnosis to autoimmune pancreatitis causing chronic pancreatitis? So that is something that we need to arrive at. So in this present video, I'll be talking about why do we need imaging in cases of chronic pancreatitis, especially such a cut and dry case. So basically, imaging can add one confirmation of tissue localization. So this patient, again, because the abdominal pain is poorly localized but significant, could it be due to something else? We saw there are other causes of abdominal pain that could essentially explain the abdominal pain, and or they could be coexistent with this disease. Okay. Second is, what about, so we suspect that there is exocrine insufficiency of the pancreas. We could technically do a stool elastase level to check for exocrine insufficiency. However, could imaging be easier way of getting assessing pancreatic exocrine function? Then finally, what is the utility of pancreatic imaging in the diagnosis of the etiology of the disease? Because again, there is no significant toxin exposure. The patient does not have a genetic history. It's very late onset. Okay, the patient has not had previous episodes of acute pancreatitis. We are suspecting chronic pancreatitis when you're suspecting, and there is that looming specter of autoimmune pancreatitis right there. So because again, this patient will be referred to me for a trial of steroids, and do I give a trial of steroids or not becomes a very important clinical question for me to answer. Now, there are, in this particular video, I'll not go into the details of this warrants a specific video of its own. That will be the next video in the series. I will, however, just formalize the findings that we get in chronic pancreatitis and talk about two classification criteria, that is the CT Cambridge criteria and the MR Cambridge criteria for chronic pancreatitis. And I'll just highlight the important salient points because again, they come in exams, and even more importantly, they give you a framework as to how to think about chronic pancreatitis and what is important. Then we'll talk about secretin stimulated MRCP, that is magnetic cholangiopancreatography, MR, not MCRP. It's a MRCP. So we'll talk about the procedure. We'll talk about imaging protocols, and we'll finally end the discussion with an interpretation of a particular case that I use as a teaching tool. This is not my case. This particular case is not my case, the one that I'll show. However, it's an important teaching tool. Okay. Now, again, usually we know a lot from the patient's history, provided you've taken the time and effort to collect the history and you analyzed it. You've used your brain to analyze the history. So we can, whenever we have a pathology, we have a pathophysiological change at a cellular and a molecular level that results in a alteration in the normal physiology of a tissue. Okay, the normal function of a tissue, and that comes forth clinically as a symptom and or a sign. Okay, so what we do is, in our particular case, we have abdominal pain, which is significant but poorly localized and is associated with steatorrhea and with new onset diabetes mellitus. So using that, I have inferred that the tissue affected is the pancreas, likely the exocrine glands and the endocrine gland, this thing, beta cells of the islets. And this I did through a process of critical analysis of the symptom and negative history targeted to the possible feasible differential diagnosis. Okay. Now, Again, I also would ask history for etiology. We used Digaro and we came to the conclusion that if it is anything, it could be autoimmune pancreatitis. And this is probably the state at which gastroenterology would discuss with me, or at least that would be the ideal stage at which they should discuss it with me. It is often not. But again, at that point, specific input into whether it could be autoimmune pancreatitis or not is warranted. It is a reasonable question to ask. So when and why would I subject this patient to imaging and possibly to a course of steroids? So what does imaging add? One is imaging can establish that it is truly the pancreas that is affected and there is a chronic pancreatitis going on. Okay, and we'll see how this happens. Second is imaging can help me quantify pancreatic function when necessary, because how much residual function is there would help me guide treatment, as in supplement pancreatic enzymes, etc. And also determine whether I need to charge steroids again. That is an important question that comes up. I cannot reverse complete organ loss. Okay, now the next thing is toxin, genetic, and recurrent pancreatitis has no specific imaging features, just like but so it is ruled out in history. So there are some imaging features, however, that characterize autoimmune pancreatitis and actually differentiate it from chronic pancreatitis. And in the vast majority of cases, you can quite reliably differentiate these disorders. So, therefore, talking about imaging in pancreatitis, essentially we divide them into parenchymal findings within the pancreas and duct findings. So, on non-contrast imaging, this could be CT or MR. I recall the typical findings or parenchymal findings in non-contrast imaging using ABCD as a mnemonic. So, A stands for alteration in pancreatic parenchymal signal intensity. This is particularly prominent on T1 and T2 weighted MRI, although you can see it in CT also. B stands for below average. Uh, Size of gland, not six. So below average size of gland. So size of gland would be loss of parenchymal volume, and we'll see there are, as we've seen previously also, there are clear cutoffs for that. C stands for cyst formation within the pancreatic parenchyma. This could be due to extracellular matrix turnover causing fusion of adjacent acini, reproducing a large cyst. It could also be due to distal obstruction of the duct, resulting in back pressure and dilatation of an existing group of acini. Okay, then you could have dystrophic calcification within the pancreas. Similarly, in the duct, you could have irregular duct dilatation. This is irregular because the fibrosis is patchy, and that fibrosis is what is pulling out the pancreatic duct away from the center of the duct. And there might be strong strictures. Shorter strictures, as we'll see, are more typical of normal chronic pancreatitis. Then, because of stasis, you could have intraductal stone formation. In case of contrast enhanced imaging, enhancement abnormalities may be there within the parenchyma of the pancreas. This is actually very obvious on both CT and MR. And then finally, duct findings on contrast enhanced imaging. Actually, there are none. Okay, so the in non-contrast and contrast enhanced imaging, duct or the pancreatic duct or the main pancreatic duct looks the same. Okay. So again, these findings require their own video, and this will be the next video of this series. For now, we'll just look at the classification criteria for chronic pancreatitis. So we have a modified Cambridge classification criteria, that is CT, which is essentially scored. A normal pancreas here is a pancreas with normal signal intensity, which is around 2 Hounsfield units lower than the corresponding liver, and early, that is arterial to portal venous phase, diffuse and uniform pancreatic enhancement. Okay, so we've seen this when we talked about imaging in acute pancreatitis. The gland should additionally be normal incised, and the pancreatic duct and its branches should be regular. There should not be any parenchymal or duct calcification. Equivocal is when we have intermediate findings. Mild is when there are at least two of the following findings. So we have a pancreatic duct irregularity. Irregularity is defined as a variation in duct diameter of more than 1 to 2 millimeters. Two is pancreatic duct dilatation, defined as a duct that is bigger than 2 to 4 millimeters, more than or equal to 3 dilated side branches. So I remember this using 1, 2, 3. Okay. Then a heterogeneously enhancing parenchyma, or just essentially just a heterogeneous parenchyma, but enhancement patterns are actually the most sensitive in that area. And then finally, a cyst that is less than 10 millimeter in size. Okay. Now, this can only be satisfied if the main pancreatic duct diameter is less than or rather less than 4 millimeters. Okay. So this can only be satisfied if the main pancreatic duct diameter is less than 4 millimeters. Okay. Now, if you have moderate chronic pancreatitis, you have a main pancreatic, you have all the features, two features of mild pancreatitis, obviously excluding pancreatic duct dilatation, and a main pancreatic duct diameter more than 4 millimeters. Next, we have severe. So we have severe if it is that there are features of moderate plus any of the following. So this can include pancreatic parenchymal calcification, cysts that are more than 10 millimeters or 1 centimeter in diameter, more than or equal to duct stones, duct strictures, or severe duct irregularity. These are very difficult to miss on imaging. So again, usually we go in the reverse order while classifying the cases. Okay, so we say no features of severe, no features of moderate, maybe mild, and then equivocal, and then again normal. Then we have modified MRCP Cambridge criteria. So again, this is not MR specifically, this is specifically for MRCP. So an MRCP is a heavily T2 weighted, usually thick slab image acquisition, usually done using some technique that decreases motion related artifact. That is, there is fast acquisition of the signal, usually something like haste. So we'll go get into that when you talk about MR imaging. Okay, so in MRCP, again, because of the heavily T2 weighted nature of the imaging, it is the fluid within the ducts that is the most prominent. Okay, so the classification is purely based on duct. So a normal duct is normal. Dilatation of 1 to 2 pancreatic side branches, not the primary duct, is equivocal. If there are 3 or more pancreatic duct side branches that are dilated, that is a mild chronic pancreatitis. Now this is corresponds with the same mild that we saw in CT imaging criteria. Okay. Now, if you have that is dilatation of more than 3 pancreatic duct side branches with MPD showing stenosis or dilatation, that again is moderate. But however, we saw in the CT case, dilatation up to 4 millimeters is still considered a mild case. Okay. Finally, we have severe, that is any case that is classifiable as mild or moderate with either a cyst or a stone. Okay, so relatively easy classification criteria. Often again, because they are exams tend to have at least a portion of rote memory being assessed. You need to be aware of these. Now, imaging in the context of pancreatic exocrine insufficiency. So there is a way to assess pancreatic exocrine insufficiency, that is through secretin stimulated MRCP. So secretin is obviously a enzyme that is a hormone that is produced by the small intestine. We'll get into the details of this at a later date. Again, primarily its function along with cholecystokinin is to increase pancreatic exocrine secretion of H bicarb as well as enzymes. Okay, so synthetic IV secretin is given at 0.2 microgram per kilogram body weight, followed by a saline flush of approximately 20 ml immediately after administration. This is so that none of the secretin remains within the the cannula. Now the patient is made to fast for 4 to 6 hours before the examination, and we can give a negative contrast in the form of 150 to 200 ml of pineapple or blueberry juice. Blueberry juice usually is not available, so we go with pineapple. Now the thing with this is that this is mandatory. Without this, we will not be able to adequately comment upon the procedure. Now, what is done is this is an MRCP, but there is a specific protocol. A coronal image, coronal plane is selected for imaging based on axial fast acquisition T2 weighted sequences. So, an example of such a sequence would be a His sequence. These sequences are actually centered on the common bile duct. So as you can see, they are centered here on the common bile duct, and then they are angled around 5 to 10 degrees from each other. So they're taken like this: the first sequence, and the second sequence, and third sequence, like this. Okay, so in each sequence, then the appearance of the main pancreatic duct is assessed, and the best view of the main pancreatic duct, whatever sequence gives the best view, that is the one that is taken. Okay, and after that, so for example, if I have selected this particular sequence, this is not a truly coronal slab. All further imaging will be done parallel to this sequence, like this. Okay, so that is the basic protocol. So therefore, an MRCP is, suffice to say, is not the same as a normal MRI of the abdomen. So after this, rapid acquisition sequences, for example, haste with a 10 to 6, 30 to 60 minute, 30 to 60 rather second breath hold is performed. So again, to reduce motion artifact. Okay. Now, these are the parameters that are assessed. You can assess morphological descriptors of the pancreas. You can also grade the exocrine function of the pancreas. So, the maximum diameter reported in tenths of millimeters. That is, in millimeters also there should be a point there. Okay. With location of measurement at 3 time points is done. That is, one is prior to secretin injection. That would be baseline. 3 minutes after secretin injection, and around 8 minutes after secretin injection. Okay. In case of visible side branches, a qualitative change in the size of the side branches and their communication with the main pancreatic duct is commented upon. In case of any cystic lesion, a change in the size and communication of this cystic lesion with the main pancreatic duct is commented upon. Then the presence or absence of any peripancreatic fluid is commented upon. This is after secretion, that is secretin stimulation. Now, in case of gradation, grade 0 is essentially there is no increase in duodenal fluid. Grade 1 is increase in fluid in the duodenal bulb only. Okay, grade 2 is increase in fluid up to the proximal third of the duodenal segment, and grade 3 is increased fluid in the distal third of duodenal segment. Okay, and grade 3 is increased fluids in distal third of duodenal segments or beyond. So this is essentially normal. This is also almost normal. So the important thing to note is here the increasing grade signifies better pancreatic exocrine function. So that brings us to the end of this screencast. So here we've talked about why we analyze the case, and we've talked about why we need imaging in chronic pancreatitis. So as you've seen that imaging can add the following to diagnosis. We can help us confirm tissue involvement. It can help us assess pancreatic exocrine function. It has utility in determining etiology. There are two classification criteria that formalize description on imaging. One is the CT modified Cambridge criteria, and then there is the MR criteria, which is actually based on MRCP. Then we've talked about secretin stimulated MRCP to assess exocrine function, talked about its procedure. we've talked about the imaging acquisition or the protocol, and finally we've talked about interpretation. So I'll see you in the next video. Thank you for watching.